FM, and the song says it all. Yeah, staying alive. But the critical question is, if you're sick today in the Republic of Ghana, how sure are you that you would have the best of healthcare? Bearing in mind that overall 32% of facilities have access to an emergency transport system for patients, and the primary level had the least access to emergency transport systems. 18% of CHIS compounds had that. Also, bearing in mind that even availability of basic equipment for examination and measurement is lower than needed, and overall only 5% of the facilities that were surveyed had the full complement of basic consulting room examination set. This is in the Republic of Ghana in the year of our Lord 2023. And what even makes this whole thing surprising is that this is actually an assessment conducted by the Ministry of Health, Ghana Health Service, World Health Organization. This morning we're joined by Kwame Sarpong Asiedu, who is a pharmacist and research fellow with Center for Democratic Development, CDD, Ghana. Kwame, good morning, and thank you very much for joining us.
Hello, good morning, Winston, and thank you very much too.
So, Kwame, I mean, not long ago you had, you delivered a lecture. You talked about how we were spending more, and you had asked whether the expenditure correlates with what happened on the ground. Well, we have the evidence here, but the question really is, do the authorities know these things? Are they aware? And all the amounts we've spent over the period, how come this is what we have to show for it?
Well, Winston, you ask a very interesting question. You said, what do the authorities know?
Yes.
But I just heard you say that this was done by the Ministry of Health.
Yes.
The Ghana Health Service, the WHO, exactly, and the Global Fund. So that should answer your question, because I guess the Ministry of Health has a minister appointed by the president, doesn't it? So if they have done a body of work like this, obviously they would see the drafts before the final document is put in the public domain. So my presumption would be that yes, they know, and they should know.
And this has not moved anybody, because they have released this document since July. They may have seen the draft, and as we speak, this is not the most important conversation within our health sector.
Well, yes, that's interesting. Again, you remember when I delivered that lecture, I said clearly that I was going to focus on the health outcomes.
Yes.
Because at that time, this document was out, and I knew the outputs were not very good. And I quite remember that on the day I was in the studio, I had a conversation in the background with Raymond, and I was telling him that if we had looked at the outputs, people would have been alarmed, and I didn't want to be alarmist, and that was why I didn't look at the outputs, and I'll explain why. You need to leverage the outputs to get outcomes. So what do I mean by that? You invest money in health. When you invest the money, it builds you hospitals, it buys you basic equipment like sphygmomanometers and all the diagnostic blood pressure monitoring and all that. That is what you use to manage the patients. And that is what, if you manage them properly, leads to improved quality of health, improved life expectancy and all that. So if the outputs are not commensurate with your health investments, then the question then becomes, how do you expect to get the outcomes that are commensurate with your investments? Because the outputs are what we call the fulcrum around which the outcomes resonate. So for me, that is why when something like Agenda 111 started, I remember on the Super Morning Show, I said, are we having the right conversation? When Professor Noah Ortega was going on about do we really need, I said, I wouldn't go into the needs assessment, but I wonder if we are having the right conversation. And I was wondering if we were having the right conversation because we had no data, as we have now, to back the health investment the executive were purporting to make. You see, and so now that you have this, and considering that, say, we've come out of COVID, and over 54% of all our hospitals do not even boast of a pulse oximeter for measuring your oxygen, you ask yourself, have we benefited from the pandemic like COVID? Because one of the things about any emergency is you need to benefit from it. Planners will tell you, don't let an emergency go waste. But if we've come out of the emergency and we do not have even up to 50% of our health facilities boasting of these basic equipment, some of which people have in their homes, then we ask ourselves again, are we having the right conversations?
I'll get back to you, Kwame. I'll get back to you on having the right conversations and why this is not a major issue in our country shortly. But first, a wise man once said, don't just make money, make a difference. And at ABSA, we believe in helping you make a difference through our personal loans. With an ABSA personal loan, you can get up to 500,000 collateral-free loan to finance your personal projects with a flexible payment plan of up to 7 years, fixed and competitive interest rates. The ABSA personal loan is just what you need to open the door to the life you deserve. So visit the nearest ABSA branch or call your personal banker to discover how to get things done. That's Africanacity, that's ABSA. Terms and conditions apply.
Now, African World Airlines, your CIMG Domestic Airline of the Year and Hall of Famer, see, think about it, for the fifth consecutive time and year, just launched their brand new mobile app. It's now super easy to book your flights, make payments, and check flight status all on your iOS or Android device. But that's not all. We have even more exciting news. We are about to celebrate our 4 millionth passenger. And you could be that lucky passenger to book a flight. Just book a flight with Africa World Airlines for your chance to win a special reward. I think it should be reserved for me. Yeah.
No, you're not part of it.
Oh, really?
We are not part of it.
Okay. No, Aaron too.
He could be part.
Okay, don't miss out on this incredible opportunity. Download the app, book your flight, and you could be part of our historic celebration. 4 millionth passenger. 4 million looks good on me, though. Yeah. Well, thank you for choosing Africa World Airlines. Africa World Airlines, touching Africa, touching the world.
So welcome to the Cybersecurity Awareness Month, and here are some tips to keep you safe as we embark on a journey to safeguard our digital lives together. Tip 1, check the email sender's authenticity before taking any requested action. Log out of accounts on shared computers or devices. Limit app access to your device's camera and microphone. Enable... I need to check this one again. Limit app access to your device's camera and microphone. Enable remote tracking and wiping on your mobile devices. Do not save sensitive information in browser autofill. Review privacy settings on smart device applications. Report cybersecurity incidents promptly to the Cybersecurity Authority by dialing 292. This message is brought to you by the Cybersecurity Authority in partnership with E-Crime Bureau with support from the Pan-African E-Commerce Initiative of GIZ founded by the German government.
Now, ladies and gentlemen, I have some delicious news to share with you today. Imagine a biscuit made from real cereal, packed with wholesome oats and grains, containing less sugar. This biscuit is not only a treat for your taste buds, but also a nutritious option for all ages. I'm talking about the McBerry Breakfast Cereal. McBerry Breakfast Cereal biscuit can be enjoyed at any time of the day, particularly at breakfast with any beverage of your choice. It's delicious, nutritious, and also affordable. It's made with whole grain oats, packed with fiber and real cereals. And good news, with less sugar. Worry no more. With McBerry Breakfast Cereal, your kids have the perfect snack they can take to school. Beware though of imitation. Remember, go for the original McBerry Breakfast Cereal biscuit and start your day with a smile. McBerry Breakfast Cereal, goodness for your morning. Of course, this advert is FDA approved.
Great, Raymond. So let's get back to the conversation with Kwame Sarpong Asiedu, who's pharmacist and research fellow with CDD Ghana. And so we've been talking about the details of this report. We've talked about, why we should be having a conversation about it. But the other part of the issue of why we should have a conversation, Kwame, somebody would want to find out, okay, why should I be worried? We say this should be the major conversation in health. He says, why should this be the major conversation? Why should I be worried about this assessment?
Well, Winston, anyone who asks the question, I would tell them to, you see, when you're reading a statement, for example, if someone said only 5% of consultation rooms have the basic equipment, the way you can read it is the counterfactual, which is 95% of all consultation rooms do not have the basic equipment. If they do not have the basic equipment, then there's the potential that they could misdiagnose you, or you could get an incomplete diagnosis. And if you live in a country where our outpatient per capita is about 1.13, which means the average Ghanaian visits a health facility once a year, it means in a year you have one chance of being properly diagnosed on the average in Ghana. And if you get that one chance wrong with our health seeking habits, I guess you can calculate the number of potential avoidable deaths that you can get into. Because if you're talking of 95% of our consultation rooms not having the basic equipment, what it means is that you can say on average, around 95% of our population risk going to such consultation rooms and not being diagnosed properly. So if you don't take your health seriously and that doesn't worry you, then obviously, yes, you would ask, why should I worry? But if you think that you are 9 out of 10 times more likely to go to a consultation room where the equipment is not adequate to actually diagnose you properly, then you would be concerned.
Great. But I mean, let's look at other parts. So we've talked about a lack of oxygen, even, isolated beds and all of that. We've talked about transport, emergency transport. I thought not long ago, Kwame, we had launched, some 300 ambulances amidst pomp and pageantry, and how that was going to transform our health sector. Why are we back to this?
You see, Winston, again, it goes back to the basic question I keep asking. Are we having the right conversations? If you remember at that time when the ambulances were procured, some of us were of the opinion that we have to have a comprehensive plan for the Ghana ambulance service. So let's say you procured even 500 ambulances. We are talking about 2018. We are 5 years down the line. We have very bad roads in the country. In that same country, we have a poor maintenance culture. So wear and tear is going to affect some of the ambulances. Some are going to break down and stuff like that. Ever since that happened, did we have any plan to say every year maybe we're going to buy 50 more ambulances to augment the stock we had? Did anybody have a maintenance plan in place for the ambulances? So when you don't do things like that, you have to always remember that your population is also growing at an average of 2.2%. Yesterday, I listened to you. You had the national statistician in your studios, yes, and he was alluding to some of these things. So your population is growing by 2.2%. So at least in everything you do to catch up with population growth rate, you have to have a planning input of about 2.2% to say, I am going to increase at a minimum this. But when you have a deficit, then it has to be 2.2% plus whatever you want to do to eat into your deficit. We are not doing all these planning with numbers backing our decision-making processes. Our decision-making from a policy standpoint has been politically motivated. And like I said in my speech, it is procurement-driven. So the person is buying these ambulances to fulfill a campaign promise, similar to we wanting to build a national cathedral because we made a promise to God. It is not to meet a long-term planning measure in health. And as long as we continue to make these kamikaze decisions, we are going to find ourselves in situations like this where we read dire statistics like this. And for me, that is where the wake-up call should start from.
And talking about this wake-up call, I mean, Kwame, I know that you engage a lot of health practitioners and those in authority here, but this is something that has been with them since July. I mean, that's when the final copy came out. Before then, they would have known the draft. Do you know of any actions that have been taken so far?
You see, Winston, the problem in most societies, not just Ghana, is that politicians take decisions when the citizenry and civil society nail their feet to the fire. Ask yourself, this report has been out since July. Which radio station, TV station, or even Twitter space has discussed the report in its totality? We are having a discussion now. We are discussing snapshot 5. You know, there are 6 snapshots in the report. This is just snapshots 5. What is in 1, 2, 3, 4, and 6? Nobody is discussing them. But this is actually a diagnosis of our entire health system. And nobody since July has spoken about it. So yes, those in policy would know, but why would they act when you've not nailed them, their feet to the fire? There are so many fires they have to put out. And as long as this is not a priority fire, why should they put it out?
But Kwame, the point is that if you are in authority, you're there to serve the interest. And so if you see these things, you should be concerned.
Yes, you should be concerned, but when you are procuring your healthcare from other jurisdictions where these things are readily available, why would you be concerned when the person, you see, Winston, this is the thing, the person who procures healthcare from Ghana would be arguing himself hoarse. We are always politicizing our arguments and arguing ourselves hoarse about who did well in our health system and fighting each other. The person who's supposed to make the decision, therefore, doesn't feel the heat and is procuring healthcare elsewhere. So why would that person be motivated? What is the driver for the person to solve your problems? Let me give you a basic example. We had elections in 2020, didn't we? And we're going to have another one in 2024.
Sure.
All political parties wrote manifestos. In 2024, I wait to see if anyone would sit down and say, this is the assessment we had in 2022, 2023. And how does your manifesto address the findings of this report, and how is it going to help things improve? Because at the end of the day, if they are writing manifestos that are not in sync with the diagnosis of the problem in our health sector, then what's the relevance of the citizenry going to vote? And those are the things. And that's why I keep going back. Are we having the right conversations?
And talking about the right conversations, Kwame, so of all the amounts that we've spent, and I mean, you've shown, for instance, in your lecture, that we've spent more than other countries, and they're doing better by way of outcomes when it comes to their healthcare delivery. So where did the money go? Where's the money?
Well, look at it from this point. Our health expenditure per capita last year was 84.98, let's say $85. Kenya is $83. Kenya has helipads and air ambulances, right? Mm-hmm. That is an output. So if you had an accident in Mole National Park, or you went to Boti Falls or something and fell, the likelihood of, if you were in Kenya, the likelihood of you being airlifted to a hospital is higher than it is in Ghana. Ghana, the likelihood is virtually zero, unless, of course, you are a high-valued citizen where the Air Force or something would have to scramble a helicopter to come and get you. So you ask yourself, how does Kenya spend $83 and you spend $85, and Kenya has air ambulances and you don't? The answer then becomes, what is the waste in your health expenditure? We have had a conversation. We are building 111 hospitals, right?
Sure.
Meanwhile, there are hospitals that were started by the previous government that are not completed. We have situations whereby hospitals are raised down to be built again. And we go on and on in these spend-drift policy decisions. And if we go on these spend-drift policy decisions, how do you expect, therefore, that we would have the same, health outputs as Kenya have air ambulances? If you go to Rwanda, it's even worse. Rwanda's is $53, but they have all these things. They do have all these things, and they have even overtaken us when it comes to life expectancy. So for me, it boils down to the citizens not having the right conversations. the citizens not valuing the fact that they have a stake in this health conversation. And as long as the citizens do not realize that they have a stake in these health conversations and they decide to decline having these conversations, then unfortunately, we are going to see these things. And when they come out as well, they are not going to be made public because it's not in your interest to see. Like I said in my speech, our politicians are good storytellers. Does this fit the narrative of them telling a good story? No. So why should they let you know that this document exists?
Great. Kwame Sarpong Asiedu is pharmacist and research fellow with CDD Ghana. Please hold on. We'll get back to you. But Raymond, I mean, let's look at a thing or two. Let's just, get back to that research because maybe people who have just joined us and they would want to know what is contained in that report put together by the Ghana Health Service, Ministry of Health, and the World Health Organization.
So the key findings, some of which you should know about, that only 38% of all facilities offering inpatient services have dedicated isolation beds. 74% of regional hospitals, 68% of district hospitals, and 36% of general hospitals offering inpatient services had dedicated isolation beds. Overall, 32% of facilities have access to an emergency transport system for patients.
Yes, emergency transport.
So you think about it for a second. The institution you are going to today may not be part of the 32% that have access to an emergency transport system. So assuming you went to a hospital and said, no, your condition requires that you be transported to a bigger facility and that you need it immediately, you might not be within this range. And think about just 32%. This is 3 out of 10.
It means 68%
yes.
don't have it.
And that's how serious and dangerous the situation is. Now, 28% of all facilities have computer with internet. 28%. Which will largely also mean that nobody is actually taking digital records of what they are doing. So, unlike other places where you go in, they have a computer there, all your details are stored on there, so you can easily retrieve that and not ask you to join very huge, useless queues, your files and folders getting missing. 28% across this republic are the ones we are talking about, and only 51% have a communication system in place. CHIPS was one of the facility type with the lowest availability of communication system, which is 36%. All regional hospitals, of course, and 92% of a district hospital have improved sanitation for clients. Now, there is also one you should know about. Hospital-owned medical oxygen sources are not as widely available as needed. Only 54% of regional hospitals had oxygen available. Regional hospitals, not the smaller units.
Yeah.
Yes, and related to that, 63% of regional hospitals had reliable oxygen therapy services. Now, there is more that I should share with you, Winston. The availability of standard precautions for infection prevention and control was generally low across all facility types. Nationally, only 31% of facilities had guidelines for standard precautions. 16% had guidelines for healthcare waste management. And 32% had staff trained in healthcare waste management.
16%?
Yes. Had guidelines on healthcare waste management.
Can you imagine?
And you can have only 32% of the staff being trained in healthcare waste management. Now, among the facilities with the main facility pharmacy store, 55% had medicines off the floor, 86% had medicines protected from water, and 84% have medicines protected from direct sunlight. Only 10% of facilities with a main facility pharmacy store had a functional thermometer or thermostat.
10%?
Yes, and 4% of facilities with current room temperature. 15 to 25% inclusive. Only 30% of facilities with a bulk facility pharmacy store meet the required standard of having a functional fridge with a temperature of 2 to 8 degrees Celsius, clean, and only used for pharmaceuticals.
This is the state of our health sector.
Which is damning, which is something that ideally would have actually occasioned the kind of things that we should be probing. Your parliament should be setting up committees insisting that this is a national crisis that they should be dealing with. Of course, they've concentrated on less useful things, but this is what everybody, be you from Bumpugu straight down to any corner of this country, because Winston, the lives we live, we do not know when any disease condition will strike. So we improve your chances of survival as a human being if some of these basic things, and these are not extraordinary standards. Let's not get it wrong. Some people have very serious extraordinary standards elsewhere. We have not reached there. These are, as we have read consistently, some of the basic requirements.
So let's get back to the conversation, and I indicated that Dr. Emmanuel Aqu, who is Executive Director for the Institute for Democratic Governance, IDEG, has a view on this. He wants to make a point. He's joined us by phone. We also have Kwame Sarpong Asiedu, still with us. He is a pharmacist and research fellow with the Center for Democratic Development, CDD, Ghana. Okay, let's get back to Kwame first before we get to Dr. Aqu. So, Kwame, let's get back to this conversation. And we've talked about, lack of basic equipment. We've talked about, even emergency services. But even when it comes to disposal of healthcare waste, that in itself is a problem. How do we deal with these going forward?
You see, Winston, that was why I said this is an assessment of our health infrastructure and inventory. That's basically what has happened. This is an assessment of that. But you see, what worries, before you can think of how to go forward, you have to think of how did we get here. What worries me is that we've come out of a pandemic where management, infection control was a priority, and management of waste was a priority, because one of the easiest ways of things like viruses spreading is poor hygiene in hospital workplaces. We've come out of a pandemic where we had to deal with vaccines, but now we are being told that only 5% of our hospitals have a functioning refrigerator that can store vaccines between 2 to 8 degrees. So we need to ask ourselves, all the monies that we have put into the management of this pandemic, if we do not have pulse oximeters, which is the basics for measuring oxygen, if we do not have functioning fridges, which is the basis for storing our vaccines, and we cannot control hospital-acquired infections, then what was our benefit from that pandemic? That is the first understanding we need to get. And when we get that understanding, how we move forward becomes very simple. It becomes very simple because yesterday, again, you had a conversation with the national statistician, and he alluded to one fact. We cannot continue taking decisions that are not data-driven in the time of AI. And that is why I keep saying, are we having the right conversations? We need to start having the right conversations that leverage around the numbers that come out of our health system's inventory. So if, for example, in 2024, a party comes and you are interviewing them, for example, and they say they've written a manifesto, this is what they are going to do in health, you should be able to ask them, how would that improve X number, Y number, Z number? Because their manifestos cannot be in isolation from the reality of our health system. You need to ask them, when they say, oh, it would improve the numbers by this, what's the fiscal space, for example, in the health expenditure per capita, the health budget, to allow you to do this? What are you going to cut, and what are you going to do differently? And those are the sort of conversations we need to have, because if we do not have the policy conversations, then our health inputs, which is the investment of our monies when it comes to health, would need to pour outputs, as you're seeing from the reports you're reading, and that would lead to poor outcomes. So the starting point should be the right conversations based on our health statistics and how we invest our money.
Great. And this morning we're joined by Kwame Sarpong Asiedu, and who's been telling us more about the Ghana Harmonized Health Facility Assessment for 2022-2023, and we've been sharing with you, some of the key findings that 38% of facilities offering inpatient service have dedicated isolation beds, and 32% of facilities have access to emergency transport. We've been joined by Dr. Emmanuel Aqu, who's Executive Director, Institute for Democratic Governance. Dr. Aqu, good morning, and thank you very much for joining us.
Good morning, Winston. Good morning.
Great, Doc. So you have a point you want to make. Please go ahead.
I was driving home from Legon. Yes, I think it's a commendable research. The gentleman at CDD, he's a pharmacist and a researcher, has done. But I think that what he's doing is to now adduce evidence to buttress the CDD post-election finding that said that 78% of the respondents are saying that the local government system is not working. And I think what he's doing is the evidence, detailed evidence we need now, sector by sector, to prove the point. Now, I heard you mention Kenya. Kenya works because Kenya is a devolved local government system. Initially, 40% of annual revenue was going to the counties. There were about 7 or 8, I think they increased them. And it's been reduced to 30-something because the president said it was taking quite a bit of the central government money. But what happened was that the allocations were released. They went to where they should go. And it started a kind of development in Kenya, which we do not measure up to in any sense, not just health, education, jobs, housing, and so on. And this is after their violence in 2007 elections and the new constitution that came into being around 2010, and they are now governing under that. So local government reform has been crucial to Kenya's development dividends, and phenomenally it's growing because institutions have been created to ensure that taxpayers' money go to where they should go, and that the services are provided, are monitored by various agencies of the state and reported. That is happening. It is not in Ghana. He mentioned Rwanda. Rwanda is exactly the case. Local government works. The money goes, is used, is accounted for, and more is added. We do not have any of those mechanisms in our country. And so it is not that we cannot do it. I think why I wanted to speak was, I don't know if I heard him fully, but it was like citizens must arise. Citizens must arise in one way that gives surety that the system will be reformed. And they must arise to vote for the reform of the local government system. It is imperative, and the executive arm, including Parliament, the whole discussion about why the executive should control, ministers should be appointed from Parliament, and party politics gets in. So the institutions in Kenya, in Rwanda, are state institutions. No party controls what, even if you're a mayor, because counties are the regional, divisions of, like we have the RegTech or the regional administrations or development agencies. They don't have the districts we have, although there's a clamor for it. So the state works, and citizens should make the state work. In this case, it's not they providing information or what, because the information is not acted upon, and the system is corrupt. And look, the district assembly command fund, Kenya is giving, as I said, close to 30. In Rwanda, it's pretty high. In fact, in East Africa, Southern Africa, it is not less. It's not more than 5% or less than 5%, as we are experiencing in Ghana. The monies never go to the local government areas in great sufficiency. Can we change it? We can only change it when we reform the system, and we make sure that the local government service is not a party-controlled institution. Neither would the ministries be, or any other agencies of state. That is state agencies. Those who work there know the law, they know the policy, and there are oversight institutions, there are investigations to be arrested and so on. That's not to say Kenya has no corruption. But things are happening in Kenya. In Ghana, it is not. So what I think citizens should do, citizens should rather hasten in wanting the reforms, the local government reforms, the referendum that will open the system, the reform of the institutions that will be state autonomous institutions. No party can control them. And they are serving the people of Ghana. They are competent to do so. We need to build these institutions. And that's why I also think that implementing the measures that have been propagated and advocated by many, that, why appoint the ministers from parliament? Kenya has that system. They appoint ministers and others from parliament because it's like a cabinet system. There's a prime minister, there's a president, and so on. Not cabinet, sorry. I was going to say it's a Westminster type, parliamentary centered. But we can do it here as well. Okay. So I like the research done. It's corroborating a very powerful information that came out that the local government system is not working. That is from the majority of Ghanaians. Those who want to vote for MMDCEs are 71%, less than the local government system. But if you put the two together, we need reforms at the two levels, concurrently, and make sure that share of common fund is jumped up to about 20, which is what the East Africans do, 20 or more. So what is 5% that is never obeyed, chopped in Accra, and it's 3% now? Even property rates at the local are being taken to the center. The center wants that money. And look at where is the local economy? Where is the employment? Where is the healthcare you are talking about? Where is the quality education? So we need some radical reforms, which we've discussed, and local government and the central government machinery. Their reform is crucial. It is a priority, and we must act on it. We can do those things even ahead of the 2024 elections, so that in the next 4 years, reforms will be implemented to change the situation. We are running a risk. If we fail to act quickly, we call for coups. We will see the worse than coups. That is when now we see the kind of small groups with arms plenty in our country now taking the law in their hands, and we are trying to stop all these jihadists and other things. It's not only jihadists who are coming. There are people, the youth are frustrated, and we must change that system. So I just thought I'll make this contribution also to assure you that it's not like Dr. Aqu is not speaking, somebody has silenced him. I just wanted to focus on reforms and not comment on everything that happens in Ghana so that we can change this country, and we have the prospect for doing so before 2024.
Thank you very, very much, Dr. Emmanuel Aqu. And so the research was actually conducted by the Ministry of Health, the Ghana Health Service, and the World Health Organization. We are very grateful that you made time to share these views with us. But Kwame, what would you say in wrapping up?
Well, Winston, my final contribution would be this. I agree with a lot of the stuff that Dr. Aqu said, that we need serious reforms. And if you remember in my last lecture, I listed 9 things that we need to do. One of which is key is we need to decouple health care management from our politics. We need to ensure that it is non-partisan, and we need to ensure that our health leaders have security of tenure to take decisions in the medium to long term. And finally, like Dr. Aqu was saying, to decentralize our health system. They are decentralized on paper. So we have this regional directors, district directors, medical superintendents, but do they get the money? Are we taking decisions that go down to the particular districts? For example, if a politician decides that they want to build a hospital, does the district director have a say in that decision? If the district director doesn't have a say in that decision, how does a politician know that these are the priorities of that district? And so the conversations have to change, and our approach to managing our healthcare must change. And we need to ensure that this just doesn't remain data on paper, but it's actually actualized in our decision making moving forward.
Great. So, Kwame, if you, I know you've looked through the document. So, from the key findings, which is the most urgent to be tackled immediately, as in now?
Well, it would be the basic equipment.
Okay.
I mean, if you go to a hospital and there's no basic equipment to get things right, that's a serious concern, and that's a low hanging fruit that can be tackled easily. So I would say that's the. But then I have to make a caveat here. In this IMF era, do we even have the money for the basic equipment anyway? And do we know which hospitals have what? Do we have an accurate inventory of what is lacking in each health facility? If we can get that done and we have the money, then the basic equipment should be the first thing.
Kwame Sarpong Asiedu, thank you very, very much for joining us this morning. And that's Kwame Sarpong Asiedu, who is pharmacist and research fellow with CDD Ghana, taking us through the Harmonized Health Facility Assessment 2022-2023. And look, only 5% have the basic equipment. 5% of all facilities have the basic healthcare equipment to actually check you if you get into consulting room. He says that is what we should be dealing with now, because if you're not diagnosed properly, you are a dead man.